Hello again, everyone. We're going to be starting momentarily, so please, everyone, take their seats. We will be starting momentarily. Thank you.
Good morning, everyone, and welcome to Braille Institute. My name is Judy Hill, Educational Programs Manager at our Los Angeles Center, and I'm pleased to have you join us for our annual Macular Degeneration Seminar and Innovation Fair. Before we begin, I'd like to give a chandelier that we have hung in near the center of the room. This is in eager anticipation of the holiday season here at Braille Institute. As many of you know, Braille Institute is a nonprofit organization. Sorry, guys. How's that? Okay. As many of you know, Braille Institute is a nonprofit organization that is dependent upon private donations for support. All of our wonderful programs and services wouldn't be possible without the support of our generous donors and volunteers. Today's seminar is made possible because of a grant from the Meta and George Rosenberg Foundation. The foundation has been generously supporting our macular degeneration seminar since 2004. Meta Rosenberg was an Emmy Award-winning television producer, story editor, agent, and director whose career spans 65 years. She was diagnosed with macular degeneration in her later years and became a Braille Institute library patron. Asked what words of advice she might give someone else who has lost one of their senses, her response was truly inspirational. "As long as you're alive," she said, "you should be living." We're grateful to the Meta and George Rosenberg Foundation and its executive director, Sue Allweiler, who has been one of our most caring donors, regularly attending events in support of Braille Institute. Ms. Allweiler, could you please stand so we can thank you for your continued support? We're very happy to have you with us today. We've also taken Meta's advice to heart with the creation of our new low vision wellness public education campaign, which provides useful lifestyle tips and information to help people with low vision live their lives to the fullest. We would also like to extend our gratitude to our community partner, Enhanced Vision, one of the leading developers of accessible technology for people with low vision, and the Retina Institute of California, the largest retina group in the Western United States. The Retina Institute's mission is to promote excellence in the care of diseases of the retina, vitreous, and macula. At the Retina Institute of California, They utilize the latest modern equipment to accurately and efficiently diagnose retinal conditions and provide all of the most current treatments, including many only available through research protocols. We would also like to extend our gratitude to both Enhanced Vision and the Retina Institute of California for supporting Braille Institute's efforts to inform and educate the public about living well with low vision and the many ways to stay connected through technology. In doing so, our partner, Enhanced Vision, has generously offered to sponsor a special promotion called Staying Connected with the Pebble. If you haven't had an opportunity to add your name to the drawing for their free handheld Pebble HD magnifier, which is valued at more than $600, we will have forms available for you during intermission. The Pebble's small, lightweight design makes it a perfect companion for magnification at home or on the go. The winner of the Staying Connected with the Pebble promotion will be drawn at the conclusion of the event today. Remember, you must be present to win. Before we begin, please take a few moments to turn off all cell phones and other electronic devices. It is now my distinct pleasure to introduce our first speaker of the day. Dr. Michael Davis of the Retina Institute of California completed his undergraduate and medical degrees through an accelerated program at Kent State University and the Northeastern Ohio University's College of Medicine. He graduated summa cum laude with a Bachelor of Science degree from Kent State University. After earning his medical degree, Dr. Davis completed his internship and his ophthalmology residency at Rush University Medical Center in Chicago, Illinois, where he served as chief resident. Dr. Davis specializes in the medical and surgical management of many retinal conditions, including diabetic retinopathy, macular degeneration, dislocated intraocular lenses, macular holes, and retinal detachment. He has published several peer-reviewed articles in a wide variety of medical journals, such as the Archives of Ophthalmology, and has presented his work at both national and international conferences. He is a member of the American Academy of Ophthalmology, the American Society of Retina Specialists, the Association for Research in Vision and Ophthalmology, and many other high-profile professional organizations. Today, Dr. Davis will be discussing updates in the diagnosis and treatment of macular degeneration. Please join me in welcoming Dr. Michael Davis.
Thank you. Good morning, everyone. Can everyone hear me okay? Okay. I see a lot of familiar faces in the crowd. I've given several talks here. And as you know, for those of you who've seen me speak before, I have a very casual way of presenting. So if questions come up during the presentation, please feel free to ask them at the time rather than waiting at the end. I'm okay with that. But I would like to maintain that if you do ask me questions, please refrain from asking any personal medical questions. General questions are okay, but nothing about your personal conditions if possible. Thank you. So this morning I'm going to be talking about age-related macular degeneration. How many people in the audience have the diagnosis of age-related macular degeneration? Good. So quite a few. For those of you that aren't familiar with it, what is age-related macular degeneration? Well, it's a degenerative disease of the retina where you basically develop a breakdown of the retina where it stops functioning quite as well. There are other forms of macular degeneration, but the main one we're going to focus on today is the age-related form. It's also the most common cause of severe vision loss in patients over the age of 50 in the United States. Well, who gets age-related macular degeneration? Well, by the name, advancing age. So it's more common in patients over 50, and it increases rapidly thereafter. So usually by 70 or 80 years old, that's the most common time to get it. It's also more common in females, and in patients who are less pigmented, so Caucasians and Hispanics more common than African Americans. Yes? Males can get it, but it happens 2 to 1 in females. So females are twice as likely to get it as males. We're not sure, but it probably has to do with hormonal changes and just different makeup of the female. Also, another risk factor is cigarette smoking. Patients who smoke cigarettes have a 7 times risk of developing more severe macular degeneration, and high blood pressure is also associated with macular degeneration. Yes, sir. So basically, there is a lot of research going on to the cause. There are several genes that have been found that increase and predispose a patient to developing macular degeneration. In the lesion you spoke of, I'll talk a little bit about in a little bit, but that's the basic lesion of macular degeneration, the drusen that you mentioned, and I'll get to that in just a minute. And it's also thought that years and years of UV exposure lead to a wearing down of the retinal tissue and allow it to be less productive in removing waste products. And that's basically what happens in macular degeneration, is you get a buildup of waste products under the retina. It's also increased with dietary factors. So high-fat diets, high cholesterol, and obesity are risk factors. High levels of zinc lower it, vitamin E, beta-carotene. So basically I tell patients green leafy vegetables, fish, and low-fat diet is good for preventing macular degeneration. Now I mentioned that it is more common in families. Yes, sir. Yeah, UV exposure. Anything that blocks UVA and UVB rays would be good. As I mentioned, it is more common in first-degree relatives, and there are some genetic tests that are on the market now. There's 2 tests that are available for determining genetic risk factors for macular degeneration. One of them is called the Macular Risk Test, and the other is called the Retina Gene Test. Currently, there are some billing issues with Medicare, so a lot of people are not doing the test at the moment because Medicare is not reimbursing for the test. But I think genetics is probably one of the future ways that is going to be diagnosed and treated in macular degeneration. General population by the age of 80 has about a 10% risk of developing macular degeneration. If you have a first-degree relative, so a parent, brother, sister, with macular degeneration, that increases to 40%. So just knowing that you have a family history of macular degeneration gives you a 4 times the risk as the general population. But again, this is a population study, so if you were my patient sitting in my chair, that doesn't necessarily mean just because you have a brother or sister or mother or father with macular degeneration that you're going to develop it. And that's why I think these genetic tests will be the wave of the future, because I'll be able to run the tests and tell you specifically, do you have high-risk genes for this disease? So how many people in the United States have macular degeneration? Early stages, about 7.5 million patients. Intermediate stages, a little bit more. High risk, dry AMD is about 3.5 million. Of those, 1 million have advanced AMD of the dry form, where they have what's called geographic atrophy, which is where you get a severe wearing away of the retina and the very central vision. So these are patients with severe vision loss from the dry form of macular degeneration. And then about another 1 to 1.5 million patients have what's called the wet form of macular degeneration. It's about 10%. About 10%. Yeah. Right, and I'll get to that in a minute because we're doing a lot of research on the dry form. Yes, sir.
Doctor, why can't we have surgery on the retina without the risk of infection?
Well, you can't have surgery on any part of your body without a risk of infection. Anytime you make an incision into your body, where you break the skin barrier or the barrier around any part of your body, there's always a risk of an infection. So, yes. So you can become what's called legally blind, where your vision in both eyes is worse than 2200, but you would not lose complete vision where you don't see any light or anything. With macular degeneration, generally you still maintain your peripheral vision. It's the central vision that's affected. So, and the problem with macular degeneration, as you know, the general population is aging. The baby boomers are now reaching their 60s, 70s. So the problem of macular degeneration, because the aging, or the population is aging, is increasing. It's estimated that, so this graph shows in the year 2000, about 1.75 million patients have advanced macular degeneration, either the dry or the wet form. By the year 2020, it's estimated that about 3 million people, so almost a twofold increase in advanced macular degeneration. And that's why there's a lot of research going on in this realm right now. And that's a lot of what we're involved with at the Retina Institute. I'm going to go over that right now, sir. I think you stole my slides because you're predicting everything I'm going to present. So I mentioned the two types. So there's the dry form and the wet form. And a lot of patients get confused because they think that they're two distinct types of disease. And they're not really two different diseases. They're really the spectrum of the same disease. So generally it starts out with the dry form, and that's the most common form. And it happens in about 10% of patients over the age of 55 in the general population. Now, the dry form can always convert to the wet form. And with the wet form in general, you get a more rapid, severe loss of vision. And as I mentioned, about 10% of patients who have the dry form will go on to convert to the wet form. Well, what is the basic lesion that we see as an eye specialist when we look into the eye? And this kind gentleman in the blue shirt mentioned the word drusen. And what a drusen is, the way I explain it to patients, it's almost like, just like you get age spots on your hand as you get older, you can get age spots in the back of the eye, and that's what we see. They're not really synonymous, but that's a good way to explain it. And what the drusen is, it's a buildup of waste products under the retina, because as the retina ages, in some people it becomes less efficient at removing waste products. And you get this buildup of the waste products under the retina, which then lead to weakening of the retina and can lead to vision loss. Yes, sir. For I couldn't hear you, sir.
We're actually having a Q&A at the
Yeah.
end of Dr. Davis's talk, so if we can just keep our questions until the end of that, then we'll have microphones for you guys, okay? Thank you.
With the buildup of the waste product, you get these yellowish lesions called drusen. And then as it advances more, the retina reacts to that, and you can get what are called pigmentary changes, which are basically these dark color changes in the retina. And as it advances, and these pictures here show that, up in the upper left, it's more mild, where you just have some drusen, which are these yellowish spots right in the center of the retina. And then you start to get more yellowish spots, and they become more confluent. And then when it's more severe, you start to get dark spots. So there are these black spots and black lines here in the retina. And so that's the progression of the dry form of macular degeneration. But even with those advanced changes that you see there, patients may still maintain fairly good vision, 20/30, 20/40. It's when those changes start to cause the retina to wear away, where you start to get what we call atrophy. And that's where the retina basically wears away over time. And you can get something called geographic atrophy, and that's where you basically have a complete loss of central retinal function and a large area of wearing away of the retina. And you basically get a complete loss of retinal cells. And the way I explain this to patients, it's almost like if you walked up and down this carpet for 80 years, you would start to see a wearing away in the trail that you were walking. And that's similar to what happens in the back of the eye. You get these aging changes that lead to a wearing away of the tissue of the retina. Now, what happens and why do we call it wet macular degeneration? Well, we call it wet because you get these abnormal blood vessels that start to grow up through these weak areas in the retina. And those abnormal blood vessels lead to fluid or water in the retina, and they can also lead to bleeding in the retina. And that's why we call it wet, because there's fluid and bleeding under the retina or within the retina. And this can lead to a severe, sudden change in vision. And this is one of the reasons why we tell our patients to continuously monitor their vision, even if they have the dry form, because a sudden change in vision where they have either new distortions or a new blind spot, it could be that they've now converted to wet macular degeneration. These next animations show this is the retina, and then this is the tissue under the retina, and these are the abnormal blood vessels that are growing up under the retina, and then the blue is the fluid that comes along with it. And the way I explain this, too, is like if you have a crack in your sidewalk, so you have a crack in your retina because it's weak, because it's getting older, you can get a weed or an abnormal blood vessel that grows up through it, and then that can cause severe vision loss right in the center of your vision. Well, why is it important to differentiate between the two? Well, one is the prognosis. The dry in general is good, or it leads to slow vision loss, and fewer patients with dry have vision loss than those with wet. And that's why it's important to distinguish, because if we don't treat the wet quickly, you can have severe, irreversible vision loss. And then it's also important for treatment. As the gentleman mentioned, there is really no good effective treatment for the dry form at this time. The only thing we can do is prevention with some vitamins and making sure the patient monitors their vision, so if there's any changes, we can catch it when it converts to the wet. Now, if you have the wet form of macular degeneration, there's some very effective treatments on the market, and we treat it basically with monthly injections of medicines into the eye. So if you are diagnosed with dry macular degeneration, basically the first thing I tell my patients is if they smoke, stop smoking. If they don't smoke, I tell them not to start. And then I talk to them about dietary modifications, like I mentioned, green leafy vegetables, fish. And then if they have severe changes or more advanced changes, I recommend daily multivitamins of special vitamins that are made for the eyes. And there's different formulations on the market. Most of them, I think, work about the same. But they have very high levels of certain nutrients that are, helpful for the prevention and of the advancement of macular degeneration. So the vitamins prevent it from converting from the dry form to the wet form. And then, like I said, the most important thing is for the patients to monitor their vision every day with, this is called an Amsler grid. So I give all my patients with macular degeneration one of these, and that's a grid that they monitor at home. And if there's ever a change where there's either a new distortion or a black spot in the grid, they need to call my office right away and come in and be checked. So what do we do for the wet form? Well, basically the same dietary modifications that we recommend for the dry form: stop smoking, green leafy vegetables. And then the patients require monthly treatments of injections into the eye, which are called intravitreal injections, which is an injection of a medication into the eye. There are three main medications that we use for this. One is called Avastin, another is Lucentis, and the newest one, which was approved about 2 years ago, is called Eylea. They all work, the first two work about the same. The Eylea works a little bit differently with a little bit of a different mechanism, but they're all very effective. But what I tell my patients is that this is a chronic disease. None of these injections are going to cure the problem. You're not going to get one shot and then be cured and never have to have another shot. Some patients need multiple shots. Some people need 3 or 4. Some people need a lifetime of shots. I have patients that I've been giving shots for over 30 times in a row for, because it's a chronic disease. And the other thing is, even if it responds to the shots and it stops bleeding and stops leaking, at any point it can start bleeding or leaking again. So that's why it's still important to monitor the patients. I see the patients every month because I want to catch new bleeding or new leaking right when it happens so that we can treat it before it starts to affect their vision. So the other point of today's lecture is to talk to you about some new things that we're doing and what's on the horizon for macular degeneration. Well, I mentioned the shots for macular degeneration, and like I said, these are monthly shots in the office, and not everybody responds well to these. So not everybody, has an improvement in vision. Not everybody dries up. Not all the fluid goes away. So one way, in medicine, we're always trying to target the exact area where the problem is. So say if you have arthritis in your knee, you're not going to take prednisone pills by mouth to help your knee because it's going to affect your whole body. You want to target it as close to the knee as possible, and that's why people get injections of medicine directly into their knee. You might think, well, I have macular degeneration, it's affecting my eye, I get an injection in the eye, and that's good enough. In most people, that is. But in some people, if they don't react, you want to get the medicine even closer to the problem. And the problem is actually, under the retina, basically towards the back of the eye. And so what we've developed is a way to deliver the medicine in a higher dose right under the area where the leakage and the bleeding is. And that's what this is called suprachoroidal drug delivery. And that's basically just a fancy term for basically passing a catheter through a space in the wall of the eye and delivering the medication back to the macula where the problem is. This is an animation of it, so this cannot be done in the office. This is done in the operating room. So that's why this is a more, not as a common therapy. But basically you pass this catheter through the wall of the eye, and then you deposit the medicine near the macula where the problem is. And that gives a higher dose of the medicine back to the area where the problem is. We don't do this very commonly, but it is something that we do at times when there are patients who aren't responding well to the injections into the eye alone. Now the next hot topic, and one of the things that we're very involved with at the Retina Institute, is stem cell treatment for age-related macular degeneration. We've developed a technique for delivering stem cells directly to the area, and this is for patients with the dry form of macular degeneration, with advanced dry form or geographic atrophy. Basically, that video that I just showed where we were passing that catheter along the wall of the eye, Tom Chang in our group developed a way to pass that catheter not just through the wall of the eye, but go through a similar incision in the eye and get it under the retina and pass it under the retina and deliver stem cells under the retina in patients with geographic atrophy. The goals are basically to help the tissue that's weak grow back, restore vision, and stop the progression of the disease. This is another animation. It will look very similar to the one that I just showed, but you may notice instead of the catheter going through the wall of the eye, it's going to go under the retina, which is where this bubble of light blue is. And then it basically looks similar. The surgery is a little bit more difficult because it's much more delicate getting this catheter under the retina to deliver the stem cells. Now, if anybody's squeamish, I am going to show a live video of the surgery. So if you're squeamish, don't look, okay? But this is the surgery. Basically, you make a cut in the outside wall of the eye, which is what's going on right here. And then we put, this is called a micro-retractor, and that basically holds the wall of the eye open so that you can get to the tissue. We use an endoscope. A lot of you may be familiar with endoscopy for, stomach surgery and things like that, but we actually have developed an endoscope that goes into the eye. So there's two surgeons that do the surgery. There's the main surgeon that's working to make the hole in the eye to get the catheter, and then a second surgeon who's observing everything on the endoscope so he can basically tell the surgeon what's going on the inside of the eye to make sure that, one, you don't perforate through the retina. That's not good if you do that, so that's what you're looking for. Then right now, it's very difficult to see, but right now we're injecting a little substance under the retina. You want to basically create a space under the retina to pass the catheter through, and that's what's going on kind of in this area right here. The catheter we use has a red blinking light on the tip. It has a beacon so that you can see where it is. It's very similar to the drug delivery catheter, but it's a smaller diameter catheter. And right now, they're inserting the catheter through the incision in the wall of the eye. And then now this is through the endoscope, and you can see here, this is the blinking red light where I'm circling here, and it's passing under the retina, and it's going to go back to an area. It doesn't go right into the area of where the atrophy is. It goes adjacent to it, and then you inject the cells, and you can see the injection of the stem cells right there, and that's where it just turned white. That's where the stem cells are being injected. So we're one of, we developed this surgery. We're one of 2 sites in the country that are now doing this surgery. It is currently in the phase 2A portion of the trial, and it's limited to patients with geographic atrophy. We have 2 teams of surgeons now at the Retina Institute. Tom Chang and Mike Samuel were the main surgeons. Myself and Dr. Josh Hedaya were just trained this past weekend on the surgery, so we're now certified to do the surgery as well. So we'll be doing many of these surgeries. So if you or anybody you know has the diagnosis of AMD with geographic atrophy and are interested, you can give us a call. Yes, sir.
Doctor, why do we not hear of eye transplants?
So there currently is no eye transplant. The eye is a very, very complicated organ. In Germany, they are working on transplanting an eye, but if you think about the eye, there's a lot of problems with transplanting an eye. One is the optic nerve. The optic nerve has millions and millions of nerve fibers that you would have to reconnect one by one if you were to transplant it. And the other is that the blood supply of the eye is very complex as well. There's 2 separate blood supplies, and basically restoring that full blood supply. If any of that blood supply doesn't work, the eye is not going to work and it's not going to live. Now, there are portions of the eye that can be transplanted. You can have a corneal transplant because it's basically an avascular tissue. There is another type of stem cell transplant. It's not the same type as this, but where people have severe surface disease. So if somebody had acid thrown in their eye or something like that, you can replace the stem cells that live around the cornea of the eye. But those are really the only transplants at the time for the eye. Like I said, this is an ongoing trial. We're currently enrolling. I did want to present one patient. He was an 82-year-old engineer. His vision was 2800 in the study eye. He underwent the stem cell transplant surgery. On the 3rd day postoperatively, his vision was about the same. By week 1, his vision had improved to 2200. By week 2, he was 2100, and by week 3, his vision had improved to 2080. Now, again, this is very early. We don't know, how long is this going to last? Does it need to be repeated again? But we have had patients who have had very good responses to this. And our group is actually, we're working with a military organization in Boston right now called the Draper Laboratories. And when we look at these patients and see why did this patient's vision improve, whereas some other patients who had the stem cells vision didn't improve, looking at it, by looking at our pictures and things, we don't see any gross differences. We don't see any changes on the pictures per se. So what we did is we sent all these images to this Draper laboratory, and I don't know if any of you are familiar with them, but they're the ones who basically track down Al-Qaeda in the mountains of Afghanistan. They take these aerial photos, satellite photos, and then they superimpose the images, and they can find such slight differences in the images that they could see, today if there's a new camp on top of a mountain or in the valley of a mountain that wasn't there before, they would pick it up, whereas, just looking at the satellite image, you may not be able to see it. So what they've done is they've taken our images of these patients, they've superimposed them, and they're actually finding these subtle differences in the images, and they're pointing out things that we as eye doctors weren't noticing before. And so now we have markers to look at. We're developing systems to look at markers to see who's going to respond to our treatment. So I think the stem cell trial is probably the most exciting thing that we're involved with right now at the Retina Institute. Because again, there's no effective known treatment for advanced dry macular degeneration, so any breakthrough is going to be beneficial. We are also involved in 2 other geographic atrophy trials. I'm just going to mention them briefly. All of them have different requirements, so if you have this diagnosis or know of somebody with this diagnosis, the best thing to do would be to call us and come in for an evaluation, and we would determine if you qualify for any of the studies. If we don't take your insurance or you don't have insurance, make sure you let them know that you just want to come in for a study evaluation, and we'll do that evaluation at no charge to you. We won't bill you for it to come in for the evaluation. But the other 2 studies that we're in for the dry macular degeneration, one is an intravenous medication, so a medication that's injected through your vein, and then the other is an injection into the eye, which is similar to how we treat wet macular degeneration, but it's a different type of molecule, and both of these are to help prevent the progression of the macular degeneration. Now the next thing I want to talk about, so the stem cell trial or one of these other trials may be helpful for some people, but some people may not qualify for them, or they have such advanced disease that they don't qualify, or they have advanced wet macular degeneration where they have scarring under the retina that these trials are not for them. Well, we've teamed up with Western University School of Optometry and UCI Gavin Herbert Eye Institute to offer our patients something that I think is very exciting. And somebody asked me about this before the talk today because they'd heard about it. And you may have seen this it was on NBC Nightly News about 2 months ago, but it's an intraocular implantable telescope. And this is for patients with either dry or advanced wet that's currently inactive. So you can't be getting current treatment for the wet macular degeneration. But if you have scarring or advanced disease, this may be an option for you. And what it is, it's basically this very tiny implant. It's almost like a cataract implant, but it's a little bit bigger because it's a telescope. And what they do is they basically remove the lens of the eye like they would for a cataract surgery and implant this telescope into that same space. So that's the caveat. So you can't have had cataract surgery before. So you have to have the natural lens in the eye in order to have the surgery done. So that's one of the requirements. But it's for end-stage macular degeneration, so either the dry form or the wet form, end-stage, with the visual acuity of 2160 to 2800. Those are the requirements. And what it does is it basically magnifies the image to reduce the impact of the scotoma. So the blind spot that you have in the center of your vision from the macular degeneration, this telescope magnifies the image to help work around that. And that's what this picture here shows. This picture on the left is without a magnification. And for those of you who can't see, but basically it's outlining a blind spot here, and the word cat is spelled out. And you can only basically see part of the C and part of the T. With the telescope, it magnifies that, so now you can see all of the C, all of the T, and then part of the A. It doesn't completely eliminate the blind spot, but it makes it so that it's more, you could probably make out what this word is by scanning and whatnot. Yes, ma'am. In the back, yes. It would not, no. I'm not sure actually what it's made out of. I think it's a polymer, it's the same material that a cataract lens is made out of. So probably acrylic and some other things. Now this is FDA approved yes ma'am, in the back. Yeah. No, if there's vision loss from the glaucoma, it won't work because you would still be magnifying it onto areas of the retina that may not be able to see well. This is FDA approved. Like I said, our center is currently involved with it, and it's actually a multidisciplinary approach. Basically, we as the retina doctors diagnose the patients with end-stage macular degeneration, see that they haven't had cataract surgery before, and then offer this to them. You would then go to Western University School of Optometry, either in Pomona or they also do a clinic out of our Riverside office. And then you would work with the low vision optometrist and the occupational therapist to determine if you're a good candidate for this. This isn't straightforward cataract surgery. You wouldn't have this implanted and then just go on the next day, just go on. It takes training to get used to using this. The eye that has the telescope implanted would be your central vision eye, the eye that you use for central vision, but you would then lose some of the peripheral vision in that eye. So they want to make sure that your other eye has good peripheral vision because you're now going to be using both eyes together in a way that you haven't used them before. Like I mentioned, it is FDA approved. You have to be 75 years or older. The visual acuity, 2160 to 2800, end-stage macular degeneration, and you cannot have had cataract surgery before. So that's one of the obstacles I'm running into is a lot of my patients at this age have already had cataract surgery, even with the macular degeneration. What was that? Glaucoma? No, you can't. This is not for glaucoma. This is just for macular degeneration at this time. Okay, that concludes my presentation. I think we have a few minutes for some questions, if anybody has any other questions. Yes, sir. And
Be coming around with microphones, so just hold your hand up.
Doctor, for the benefit of our audience, if we're going to buy a new television, which size screen should we buy to see best?
the bigger the better, right? I think it's dependent on every patient. I mean, what I would recommend is, going to a store where they have a lot of different options for you and kind of stand back, judge the space in your home and stand back and see which one would work best for you. It's really hard to say, but, my grandmother has macular degeneration, and I think she has like a 80-inch TV or something. So, I mean, each to each his own, and if you don't have the space for that big TV, you might have to sit closer. So it's definitely very patient specific. So.
Yes.
And I don't have any financial interest in television companies.
Hi, yes, doctor. It seems that the cause of macular degeneration has not really been determined yet. Is that correct?
That's correct. It's multifactorial, meaning there's a lot of causes to it. There's probably not one single cause.
Right, but I've been reading various opinions, and some people say maybe one of the causes is that when the circulation to the eye is not functioning properly, then like the toxins build up like the drusen, and also the nutrients and the oxygen and the detoxification doesn't take place. So in other words, so if it could get all those things, maybe then it wouldn't occur. So has anybody researched that or doing anything about that possibility?
Not that I'm aware. I mean, I know we look at blood flow and things, and there aren't. We haven't seen specific. People can get decreased blood circulation that we can see on our pictures, and I haven't seen any of that associated with macular degeneration. But certainly, high blood pressure, high cholesterol, all of those things which affect blood flow in the vascular system are also risk factors for macular degeneration. So I wouldn't be surprised if there is some component of circulatory issues with it as well.
And also, I was wondering, like outside of the United States, is there a lot of research going on with stem cells and gene therapy and other things which have not yet been approved here by the FDA, but maybe might be clinical trials going on in other countries? Do you know anything about that?
I'm not that, other than the eye transplant in Germany, I know there are other methods of stem cell transplantation that people are trying for macular degeneration. The problem with the way that a lot of people are doing it is they're going inside of the eye and making a hole in the retina and then injecting the stem cells that way. The problem with that is those stem cells are very active and they will come out of that hole, cause a lot of scar tissue in the center of the eye, and cause a retinal detachment. So our method of going from the outside in, where we don't ever make a hole in the retina, we have not shown that have any of those complications like others have. So.
Oh, we have a question right here.
Hold on. They'll bring you a microphone in just a minute, okay?
You were mentioning about the vitamin and taking nutrients. Now,
Yes.
Is that going to stop the progression, or
So
is it,
the
are
main,
you,
the
are you
main
gonna
goal
continue
in what
to
the
use it?
studies looked at were to prevent it from progressing from the dry form to the wet form. I did have one patient who went very strict on his diet, and he actually did have a reversal, and I had the pictures to show that his drusen actually improved with his diet, where when I saw him, he had very few drusen, but he brought me pictures from his previous eye doctor where he had many drusen. And his diet was, I don't know if anybody could handle the same diet that he was on, but it was very regimented. But I think certainly with a very strict diet, you probably could reverse some of the changes, but the main goal is to prevent progression of the disease.
I'll repeat it again. What percent of the people can become blind with the macular degeneration?
So it's hard to say, but probably, with the wet form, all of those patients theoretically have the risk of becoming blind. And before we had these treatments, most of them did, because we didn't have effective treatment. Certainly it's less now, but I don't know off the top of my head how many. About 10% have severe vision loss from macular degeneration. Certainly that's improving now that we have treatments for the wet form. And if we can develop a treatment for the dry form, hopefully that number will improve even further.
Okay, we have a question over here.
Doctor, at the beginning of your presentation, I heard the term dislocated ocular implant. Are you talking about a lens that was installed like during cataract surgery getting dislocated, and what would cause that?
So there's a lot of things that can cause it. Some people, you're correct, I am talking about after cataract surgery if the intraocular lens becomes dislocated. Some people are predisposed to it because when you do cataract surgery, they put the lens into a natural bag that's in the eye. And in some people, that bag isn't as strong as in other people. And it may seem at the time of surgery that it's going to last, but after years and years, and I've seen it 20 years later, where that bag becomes loose and the lens either dislocates completely or it comes out of place a little bit. And usually when that happens, it's a retina surgeon that has to go in, and because we have to go back to the back of the eye and either take the lens out or suture it back into place, stitch it back into place.
I was just wondering, are there any vitamins or supplements that would help for the wet macular degeneration?
I recommend the same vitamins. They don't stop the bleeding or stop the, they don't really necessarily help the wet more than they would the dry, but you know, it helps the other eye. So if the other eye hasn't converted to the wet, it could prevent. And if I have patients with bilateral wet, I still recommend the vitamins. You know, the main goal is to prevent it from becoming wet, but certainly taking the vitamins wouldn't hurt. And you know, if you can get it to dry up, those vitamins may prevent it from bleeding again or leaking again.
Okay, guys, we have time for one last question over here.
Hi, doctor.
Hi.
I need to ask you. My mother had laser surgery for her cataracts, and now she's having problems with her with lighting. Is there any recommendation that you can give me if I can pass the information to her?
Yeah, I mean, the only thing I could recommend would be for her to, you know, be evaluated by an eye doctor to see exactly what the cause is. It's hard to say.
Okay, everybody, let's give a big round of applause for Dr. Davis. Thank you so much. Now, we are going to be taking a brief break for the next 5 to 10 minutes. If you haven't had the opportunity yet to sign up for the Pebble drawing, it'll be outside at the sign-in table. So let's give about 10 minutes for a break, and then we will start with our next presenter. Thank you. Hello, everybody. Welcome back. It's now my pleasure to introduce the next speaker of the day, Dr. Jeffrey Huang. Dr. Huang received his undergraduate degree in psychology from the University of Southern California, where he graduated with Presidential Scholar Honors. He completed his graduate studies at New York University, where he received his master's degree in clinical psychology. After spending a number of years working as a healthcare research analyst at PacificCare, one of the largest HMO companies in the country, he attended Touro University to complete his medical degree. Dr. Huang completed his ophthalmology internship and residency in Las Vegas, Nevada, and joined California Eye Care and ear specialists to continue to provide exceptional care to his patients. He is a board-certified ophthalmologist and eye surgeon with a focus on cataracts and glaucoma, and is a member of the American Academy of Ophthalmology, the American Osteopathic Colleges of Ophthalmology, among other professional organizations. Today, Dr. Huang will be sharing helpful information on the latest updates in the diagnosis and treatment of glaucoma. Please join me in welcoming Dr. Jeffrey Huang.
Good morning. Hope everybody can hear me okay. I heard from the audience a number of excellent questions that were asked at the end of last lecture. We'll try to save those until the end. Sorry, I have a kind of a soft voice. I'll try to speak up. So thanks for having me. Here to talk about two of my favorite subjects, one being cataract and the other being glaucoma, and we'll see how much we can cover depending on how much time that we have, okay? So let's talk about cataracts and what is a cataract. Cataract comes from the Latin word cataracta, which means waterfall, and what it is, it's a medical condition that leads to a progressive clouding of the lens that's normally present inside our eye. And for those of you that can see this diagram up here, this is a cross-section of what our eyeball looks like. And the entity that becomes cloudy over time is this thing right here. That's our lens. And when we're little babies, this lens starts off as perfectly clear piece of protein. And as we get older, as the result of exposure to sun, it just changes. That happens to our body as once we get older, that lens starts to get cloudier and cloudier. What I tell my patients is that our eyeball functions a lot like a camera. Every part of it needs to be working in order for us to properly focus light onto the retina. So the cornea, as well as the lens here, both act as focusing points so that the light can come into a sharp focus in our retina. So everything needs to be working in order for you to have good vision. What happens in somebody who has cataracts is that the lens gradually gets cloudier and cloudier, and at some point it becomes so cloudy that the light is no longer able to come into our sharp focus in the back of the eye, and instead, when light tries to come in, it scatters all over the place, kind of like how it is there in the bottom. For patients who have cataracts, what they'll typically come and notice is that they start having difficulty with their vision, especially either in the distance or up close. Some patients will also tell me that they're starting to notice difficulties in terms of discriminating between colors. And some patients will also notice if they drive at nighttime, the lots of halos and glares, especially coming from the oncoming traffic. So what are the causes of cataracts? The most common one is aging, and if anybody out there in the audience knows a way to prevent that from happening, come talk to me afterwards. We'll bottle it and sell it, so I can retire. No, but all joking aside, that is, like I tell my patients, dogs get cataracts, horses get cataracts, we get cataracts. It's just whoever made us this way. It's not a big deal. Some of the other causes that can cause cataracts include trauma. Accidental baseball or golf ball to the eyeball can cause that to happen as well. The third cause for cataracts is radiation, both from a medical standpoint, meaning that if you receive radiation to the head for some type of, let's say, cancer or treatment, or the radiation coming from the sun. Believe it or not, UV light coming from the sun is actually one of the main causes for the development of cataracts. So if your cataract, or if your eye doctor tells you that you're starting to have the beginnings of a cataract, wear sunglasses. Wear some glasses that have good UV protection to shield your eyes from the UV light that's coming from the sun. Last but not least, there are certain types of drugs that lead to the development of cataracts. One is smoking. Nicotine and tobacco has been shown to increase the speed at which a cataract develops. And also, the use of steroids also speeds up the development of cataracts as well. And there's a couple different types of steroids that do this. The most common one being the ones found in nasal sprays and eye drops. We're going to try to save the questions for the very end, so remember your question, please. Okay. So there are 3 very common types of cataracts that I encounter. They all have really fancy names, but I'll try to go over those and show you pictures of them to see, so you guys can see what it looks like. The most common form is something we call nuclear sclerosis. What it is that the inner portion of the lens in our eye gradually turns darker and harder, and that's the most common type of cataract. Another type of cataract is called posterior subcapsular, and that particular type of cataract is typically associated with certain disease states, typically diabetes, and patients who have been on chronic steroid use for a long period of time for other medical conditions. Last but not least, we have the cortical cataracts, which the fibers of the cataract gradually change in their water content, leading to a very typical quarter-like appearance. And here's a picture of somebody who's got the nuclear sclerosis type of cataracts. And you can see from the picture here, what we're looking at is this brown darkening change to the color of the lens that occurs as we get older. Here's a picture of somebody who's got some cortical cataracts, and you can see from the photo here, it does look like the spokes of the wheel that's radiating outwards. And this is a picture of somebody who's got posterior subcapsular cataracts that's typically associated with somebody who's either diabetic or has been on steroid use for a long period of time. So what's the treatment for cataracts? Well, unfortunately it involves surgery. But the good news is that cataract surgery is the most commonly performed procedure in the United States in adults over the age of 65. It has a 95% success rate in terms of allowing the patient to see better following the surgery. However, with that being said, all surgeries carry a risk of complications, and there's 3 that I tell all my patients about. Number 1 is bleeding, okay? Not from the front part of the eye where I'm working, but bleeding can happen in the back portion of the eye, especially in somebody who's got uncontrolled high blood pressure. Fortunately, that's extremely rare. I've never seen a case of it, and especially with the changes that we have and the new advances that we have in surgical technique, it's becoming rare and rare. Possible complication number 2 is infection. You know, as with all surgeries, there's a risk of infection. Fortunately, that's extremely rare. I have my patients use an antibiotic eye drop a couple days before the surgery and up to a week after the surgery to prevent that from happening. Possible complication number 3 is that sometimes months and years after a patient has their original cataract surgery, a hazy scar sometimes develops behind the clear artificial lens implant. Fortunately, there's a safe and effective treatment to get that hazy scar out of the way if that was to develop. Let's see if this video plays. It doesn't.
fluids are injected into this incision to support the surrounding structures. The top of the lens capsule is then removed to gain access to the cataract. The surgeon then uses ultrasonic waves to fragment and emulsify the clouded portions of the lens. They are then removed. Once the cataract is removed, an intraocular lens, or IOL, will be placed into the empty lens capsule. Small struts will hold it in place. Once properly positioned, the synthetic IOL restores the patient's vision.
It's normal following cataract surgery for the vision to be blurry for a couple of days, which will clear up after a few days. It's important during this postoperative period to continue using your eye drops as your physician instructed, and you're forbidden to do a couple things for about 2 weeks following cataract surgery. Number one, there's no swimming with your head underneath the water, and that's to decrease the likelihood of an infection from developing. Number two, no vigorous exercise and no heavy lifting. So if you're training to do this, you gotta put your training on hold. So. Excuse me. So when is it time for cataract surgery? That's a decision that you need to have with your ophthalmologist, and it's based on a couple factors. Number one, how good your vision is with glasses, and how good we can get it to with glasses. And if we can't get your vision beyond a certain point, even when we try to update your glasses, it may be time to think about cataract surgery. Number two, it depends on what we see on our exam. If it looks like you have a pretty severe cataract, we'll definitely let you know that it may be time to consider having surgery. And last but not least, the patient will tell us how much their life is being impacted by the presence of a cataract. You know, if a truck driver comes and tells me that I'm noticing a lot of difficulties, especially with glare and halos at nighttime, I don't feel safe to drive at nighttime anymore, that's something I definitely take into consideration in terms of discussing possible surgery with the patient. When it comes time for cataract surgery, you have a couple of different lens options, and there are three broad categories. One is the monofocal lens, which is it's the standard lens that's covered by insurance. And with this particular type of lens, we ideally try to set the power of the lens so that the patient can see well off in the distance, but they'll need to wear glasses to be able to see anything up close. Toric lenses are designed for patients who have high amounts of astigmatism, and these lenses work really well in terms of reducing the amount of astigmatism that may be present after cataract surgery. And last but not least, there is the multifocal lens. And the way these lenses are designed is that it allows the patient to be able to see things up close with less dependence on glasses after cataract surgery. That picture up there just shows you some of the different available lenses out there. You know, there's no one lens that works the best for everybody. And that's a discussion that you need to have with your ophthalmologist when it comes time for your surgery to figure out which lens may work the best for you, depending on your needs. All surgeries have a certain amount of risk, and even though cataract surgery is a very safe surgery, there still is an inherent amount of risk that you need to take into consideration. And secondly, not everybody responds to cataract surgery the same way as your neighbor. So just because your neighbor saw great one day after the surgery may or may not mean that you're gonna see great one day after surgery. And the final visual outcome is ultimately gonna be impacted by what other concurrent medical conditions you may have affecting your eye. So for example, I know some of you were asking earlier, if you have glaucoma or if you have macular degeneration, is my vision going to get better? There's no straightforward answer to that, because all these other disease entities can end up impacting the health of your eye even after successful cataract surgery. Just a brief note, there's something that came out within the past 2 years, and what it is called femtosecond laser-assisted cataract surgery. Up until 2 years ago, everything that was done in cataract surgery was done using an ultrasound machine. However, some very smart person took the technology that was used in LASIK surgery and took that technology to replace a couple of the steps that we typically had to do with our hands that were highly surgical, surgeon dependent. And what it means is that it's safer, especially if you have certain eye conditions, which would make your cataract surgery a little bit more complicated. Questions? Yes, sir.
Notice that you didn't mention progressive or transitional lenses. How come?
Progressive lenses and transitional lenses are two different types of lens materials used in your glasses. Progressives refer to a graduated cylinder which allows the patient, it's basically a no-line bifocal where the top part is used for your vision and the bottom part is used for reading. And the thing about progressive is that there's no line in your glasses, and that's why it's called a no-line progressive lens. Transitions refers to a different type of lens material that can be used for your glasses, and what the transitions do is that they automatically turn darker when they're exposed to the UV light. So rather than putting on a separate pair of sunglasses whenever you go outside, these glasses simplify things for you and just gradually turn darker over 45 seconds whenever you're outdoors. So you don't have to worry about putting on a separate pair of... Not always. It depends on your needs. Polycarbonate is a good material. It's durable. It's scratch resistant, but it's not for everybody. If you have a very high prescription, you may need something like high index glass to reduce the thickness of your lens.
Okay, we have a question over here.
Is there an age requirement or specification for people that have cataract surgery?
No. It all depends on how much it's impacting the patient's vision. I mean, cataract surgery can be done as on 1-year-olds. Some patients are born with cataracts, called congenital cataracts. Yeah. Hang on one second. We're going to take turns.
We have one question over here, so hold on.
You mentioned earlier about cataracts and causes, and then you said smoking, steroids, and did I understand you said eye drops? What kind of eye drops?
Steroid eye drops.
Oh, steroid.
Steroid eye drops, yeah. Chronic use of certain steroids, including steroid eye drops, can lead to the development of cataracts.
Okay, if you have a question, just raise your hand, and I think there was one over here. Hold on one second.
Oh, well, you have an operation of glaucoma. The glaucoma return again after years?
It's possible for the glaucoma to return. So what glaucoma is, it's a disease state most commonly associated with elevated intraocular pressure. So what we do to try to control glaucoma, by and large, is try to reduce the pressure inside the eye. And whether that's with eye drops, lasers, or surgery, we do whatever it takes to keep that eye pressure as low as we can so that no further damage is done to the optic nerve.
Okay, we have a question over here.
What about people who've had heart transplant and they have they take a high dosage of steroids? Okay, can you still do the operation on the eye?
Absolutely. I have patients who previously suffer from breast cancer or cancer elsewhere in their body, and they have had to undergo extensive radiation or chemotherapy. And the cataracts kind of just happen as a byproduct of all the things that they had to go through to save their lives. So absolutely, we can do cataracts to help improve that.
Okay, we have another question over here.
Doctor, referring to glaucoma, could you tell us what a good optimum number is for the pressure? And secondly, having had cataracts installed, what can I, or anyone, expect from those lenses? Are they subject to some of the vagaries of the lenses that we were born with? Are we going to have more problems?
Okay, so responding to your first question, unfortunately, there's no magical number that's right for everybody. You know, basically, I tailor the treatment so that the pressure is kept at a level, whatever that number might be, so that no further damage to your optic nerve occurs. And for some patients, let's just say they need a pressure of 16. But for other patients, they might need a pressure of 9 to prevent further damage from occurring. It all depends on the patient and where they are in terms of the health of their eye. As far as your second question is concerned, all these different types of artificial intraocular lenses have been tested, and they last longer than we do, basically. So you don't have to worry about them degrading over time or falling apart over time. They last longer than we do. So,
is the cornea affected at all during the cataract surgery? And is that why there's a different astigmatism lens?
Well, the cornea is typically not affected during cataract surgery, but there are certain diseases that affect the cornea, which we take special precautions during cataract surgery to try to prevent any additional damage done to the cornea in patients who have, quote unquote, more fragile cornea to begin with, such as Fuchs. I don't know if, anyways, yeah.
Okay, we have another question over here.
Hi, I'm having surgery on November 11, and this is my first one, but I don't have any cataracts or glaucoma. And my question is, should I be afraid, or how long is the healing, or when can I start school?
Depending on the type of surgery that you're going to have, that's a conversation that you need to have between you and your surgeon in terms of what the expected recovery time is going to be and what are the precautions that you need to follow during the post-operative period. So it's hard for me to tell you exactly how long or how quickly your vision is going to come back following any sort of eye surgery.
Okay, question over here.
If your vision is so low that you're rated legally blind and you start to get cataracts, is it worthwhile having them worked on? Or?
That is a fantastic question. So for patients who may be suffering from another eye condition such as macular degeneration.
No, glaucoma.
Or glaucoma, okay, or glaucoma. The best way to put it is this. If you think of a camera, everything needs to be working for your vision to be good. So in glaucoma, typically the nerve or the cable that's responsible for bringing the vision back to the brain has been damaged, okay? There may be a chance that by replacing the cloudy lens with a clear artificial lens may give you a clearer signal, but if the damage from glaucoma to the cable is so extensive, then no.
Okay, we have another question back here.
Are transitional sunglasses as good as putting on regular sunglasses?
So the main thing with any sort of glasses is that it needs to offer good UV protection. Some patients will tell me that the transitional glasses don't turn quite as dark as they like as normal sunglasses, but that's more of a personal preference thing. As far as I'm concerned, as long as the glasses or sunglasses offer good UV protection, that's all that matters. Yeah.
Question over here.
Is it okay to use steroid eye drops if you have both cataracts and macular degeneration? And also, are there any bad side effects from overuse?
Typically, we don't prescribe steroid eye drops for a patient unless there's some sort of indication for it. And steroids can be used to treat lots of different things that occur in the eye. If your ophthalmologist is telling you to be on the steroids, by all means follow his direction. If the cataracts develop as a secondary byproduct after being on the steroid eye drops, we can always deal with it.
Okay, we have time for one last question. It's back here.
I think you answered one of my questions before she came back here, but the question concerned that once you have the operation for the cataracts, it's not necessary to be repeated or anything else done. But the other one is, you mentioned about the insurance. One of the lenses that you use is more commonly used. And then the other one, you said where you can see closer. Is that just a matter of finances that you're saying that? Because is the second one better where you could see closer? Well, I'm going to let you ask.
So in response to your first question, cataract surgery only needs to be done once. You know, they don't grow back unless you have that hazy membrane that develops in 10 to 15% of the time. That can occur, you know, months and years after you've had the original surgery. So yes, cataract surgery only needs to be done once per eye. As far as your second question is concerned, so Medicare covers the monofocal lens. And with that particular lens, it's set that there's only one focal length, and ideally we try to make it so that the patient can see well off in the distance, but they have to wear glasses to see things up close. The multifocal lens and the toric lens are not covered by any type of medical insurance, so there's a substantial amount involved in the cost of this lens that you would have to pay out of pocket for. We can talk afterwards. So.
Thank you very. Let's have another round of applause for Dr. Huang. And also continue for Dr. Davis, who is not here. Another round of applause for Dr. Davis. We want to say thank you to that. Okay, and soon, and in just a couple minutes, is going to be that time everybody's been waiting for, the raffle for the Pebble, for all of you who are here and present to win. So, as you know, Braille Institute is a major proponent of using technology to help you stay connected to the world around you. And we'd like to thank our partner, Enhanced Vision, a leading developer of easy-to-use magnification devices, for their commitment to accessible technology for people with low vision. So I'd like to welcome to the stage Mark Greggett of Enhanced Vision, the sponsor of today's drawing. He's in the back. He's making his way, so let's keep that applause up. Here he comes. Here's the gentleman of the hour.
Thank you, Christina. I appreciate it. Hey, everybody, how are you? It's good to see a lot of friends in here. I appreciate you coming out today. And we just came out with a new product. It's the Pebble HD. It's been out for about a month or so. Very, very popular. So what we wanted to do today is give one to one lucky person in the audience. Okay. And if you want to do the honors, drum roll, please. All right. Christine Valdez. Will you put your name in here? Come on. No, I'm just kidding. All right. Lou Simon. Is there a Lou Simon in here? There he is in the back. Come on up. Congratulations. All right.
Lou, why don't you come on up to the stage right up here. Let's keep that round of applause going for our lucky winner.
It is. It's the Pebble HD.
That actually completes the presenter portion of our day. There is a technology fair that is going to be happening outside in the hallways, as you saw, from 1 to 2 o'clock. And also, for any of you who are interested in reviewing, we are going to have this on our YouTube channel. So if you go to youtube.com/Braille Institute, you can watch everything that you saw today online through our streaming. Okay? Thank you so much for coming, and enjoy the technology fair. And anybody who got lunch, just go ahead, head on over to the cafeteria with your ticket that you were presented with, and then you could pay there. Okay? Thank you so much. Have a great day, everybody.